This first call fits the category of calls that sneak up on you because the paramedic began transporting based on what the hospital told him is wrong with the patient, and some point during this transport, he began thinking maybe something else was going on. There are a couple opportunities here for changing the way in which we do an assessment or changing some of our assumptions. And also there were a couple other missed opportunities that the paramedic after the fact realized, maybe I should have done this, maybe I should have done that, and brought it to my attention and asked for my input. I think it's a cool call, and I have the patient outcome as well, which is a big deal. So that's why we're making this our first case review under this topic. So looking at the patient care report, we have a male patient, 57 years old, 350 pounds or Wisconsin average, with a chief complaint of VTAC with a pulse. That'll get your attention when you walk in the door and you find out that's what you're transporting, right? We do have chest pain as a primary impression, so the dysrhythmia is in fact symptomatic. Under this section of patient history, we have a pretty good list of medications going. I am fascinated by how they figured out this guy is allergic to formaldehyde, but it might be a little bit early to consider that for this patient. And then under the overall patient history, my goodness, this is all the comorbidities here, right? We have COPD, we have CHF, he is a dialysis renal failure patient, hypertension, obesity, and type 2 diabetes. That's just about checking every box on the comorbidities list. Looking at the section of the patient care report with the ECG interpretations, you'll notice that we have 3 leads listed, and the interpretation is the same, VTAC with a pulse. However, the paramedic on the last one added a notation that the MI is suspected. This would lead us to immediately want to see the 3 leads in order to see that VTAC and talk about it. This is the first rhythm strip that the crew collected on this patient. And you'll remember this is a patient that the hospital called for us to come get them because they are in VTAC with a pulse and they need to go to a higher level of care. So the first thing we want to ask is this VTAC? Now, just because the hospital found VTAC earlier doesn't mean the patient is still going to be in VTAC, so it might not be VTAC. And it's also important for us to monitor for any changes, so we need to be aware if the rhythm has changed. We have EMTs, AEMTs, paramedics, and CC medics all working here together. Some of us have already reached a conclusion about this rhythm, but I want everyone to be on the same page, and I'm talking to all levels of license here. So let's go over a couple fundamentals of what paramedics are looking at when we look at this stuff. You'll notice that these rhythm strips are all printed out on graph paper, and the graph paper has big boxes on it, and it has little boxes on it. The little boxes here are equal to 0.04 seconds. 5 of those across are the equivalent of 0.20 seconds. And if you count out 5 of the big boxes, 1, 2, 3, 4, and 5, that's the equivalent of 1 second. Why is any of this relevant? Well, this lets us time out the beats and make some measurements. One of the things that we get taught in paramedic school is to memorize a few numbers. So if we find a rhythm like this that lines up more or less with one of the big box grid lines, then the next big box over, if the next rhythm were to fall right here, that would be a rate of 300 beats per minute. The next big box is 150, the next one is 100, and then we have 75, and then 60, and it goes on, 50 and 43 and so on. So we can take a look here at this QRS complex, which lines up almost exactly, it's a little bit on the inside, but it's almost exactly on this big box grid line, 300, 150, 175, and then you'll notice it's a little bit early. So it's going to be a little bit faster than 75. If I were looking at this rhythm strip in the back of the ambulance, I would come to a conclusion that this is more or less 80 beats per minute for a rhythm. But it's not all about timing. Sometimes it's about measuring the amount of time it takes for certain parts of the heartbeat to happen. And to talk about that, we oftentimes will discuss things in terms of milliseconds, not in seconds. So it's important to understand that this same number here, 0.20 seconds, all we have to do is add a 0 and move the decimal place over to the thousandths, which is what the milli means in milliseconds, and that becomes 200 milliseconds. So 0.2 seconds is the same thing as 200 milliseconds. And the reason that's important is because we have a rule about whether something is a wide or narrow QRS complex. So right here we have the Q beginning right here. Down we have the Q wave, and then the R, and then the S wave ends right around here. And if the QRS is greater than or equal to 120 milliseconds, which again is going to be like 0.120 seconds, but let's talk in milliseconds now. That what we do is we take a look at the little boxes and we count them over, and if it's more than 3 little boxes, then this is a wide QRS. And this is definitely more than 3 little boxes, so we can check off this is a wide QRS complex. Now back to our original question, is this VTAC, right? So one of the characteristics we know of VTAC is a wide QRS complex, so we definitely have that going on. But the next question is, how rapid is it? And here we have a measured heart rate of 82, which was pretty close to the estimate that I had earlier, right? But if it ain't tachycardia, then it isn't VTAC. VTAC has to be tachycardic, otherwise it wouldn't be called VTAC. So for the moment, we're going to come to the conclusion that the first rhythm strip is not VTAC. And therefore, I have to respectfully disagree with the paramedic's conclusion that the rhythm strips are VTAC with a pulse. Later on in the transport, we have a second set of rhythm strips in 3 different leads to look at. I'm going to zoom in here. Here we have lead 1, and the monitor for some reason is thinking that the heart rate is 12. That can't possibly be right, but you remember the trick we just learned, right? We find a QRS complex that more or less lines up with one of the large grid lines. I would say this qualifies right here. And then we find where the next one is, which is roughly right here, and we start counting big boxes over 300, 150, 100, 75, a little faster than that, so this is probably an 84 or so beats per minute, because that's how long it took for this beat to be repeated here. We can also see in lead 2, boy, that got messy. The magic of editing. And we have a heart rate here of 79. And scrolling down, we have lead 3 and a heart rate there of 85. So again, following the same rule, it can't be VTAC if it's not TAC. None of these are tachycardic rates, so none of these would qualify as being ventricular tachycardia. I can totally understand why the paramedic took one look at the monitor, saw a wide QRS complex, and was predisposed to think VTAC, because when we go to a hospital here and the first thing they say is you got a patient with VTAC with a pulse, that creates an expectation in our mind that that's what we're going to see on the monitor. And we have to maintain our critical thinking and our double checking of what we're being told at the hospital, because what we're being told isn't always the 100% accurate story. Here's the narrative here, and we have the fact that the transfer of care report had VTAC with a pulse. The patient came in with chest pressure after dialysis, and the patient was noted for having numerous abnormal labs. Abnormal labs is another thing that's different in EMS than it is in nursing, because anything that's outside of the normal range, they immediately mark as abnormal lab, and they start ticking off the number of abnormal labs, and they get more and more worked up over them. But what do we have for lab values here? Prior to arrival here, these are the lab values that were given to the paramedic. A sodium of 128, that's a little low. The potassium is 4.3, that's okay. Calcium is okay too. The hemoglobin, 12.3, a tad low. Hematocrit, 39, a tad low. None of these are eyebrow-raising numbers, though. So when the report comes in, oh, he's got numerous abnormal labs, you have to take that all with a grain of salt, too. And then the staff indicates that the patient is on an amiodarone drip and a heparin drip. So back here, we'll notice prior to arrival, we have a heparin and amiodarone infusions going. The heparin's at 1,000 units an hour, and the amiodarone is a 0.5 milligram per minute. Here's the rest of the narrative, and if you want to read it, you can hit the pause button and read it more carefully. I do really like how the paramedic lists the amiodarone dosing, and then also the milliliters per hour that the dosing calculated out to, the heparin, and the milliliters per hour there too. Very cool to include both of those in there. What we don't have here is a 12 lead. Fortunately, the hospital did a number of 12 leads and included them in the paperwork, so we can take a look at the 12 leads that were done prior to our arrival. My goal here is to do a quick analysis of a 12 lead in a way that non-paramedics are going to find meaningful as well. So I'm not going to go into a tremendous amount of measurement and detail and super analysis here, but I do want you to know what it is we're looking for. So this is the first 12 lead here. It was done at 1946, and I need to answer the same questions I need to answer on every 12 lead. I'm going to put my cheat sheet right there, which is this rhythm sinus or not? I always start with a glance at the PR interval. If there's a number there, the computer thinks it's a sinus rhythm, and later on when I look at the individual leads, I will confirm that. Next thing is irregular or irregular. You need a longer strip here, so we'll take a look here at the long monitoring strip here. And if you look at that, I think you would have to say this is a pretty irregular rhythm. More on that later. Is it a wide or narrow QRS? QRS duration is right there. The magic number is 120. If it's above 120, it's wide. If it's below 120, it's narrow. So this is a narrow QRS as far as the monitor is concerned. And then what is the axis? The axis number is listed right here. In this case, however, it's going to be a little bit less important because I can't help but notice pacer spikes in various locations throughout. And if it is a paced rhythm, that's going to throw the axis off. So that is less important for me to focus on right now. And the last item is, are there any signs of ischemia? Ischemia is ST elevation and ST depression and a couple other things. The ST elevation, STE, that's what the STEMI is. ST elevation, MI, myocardial infarction. So I'm looking for STEMI or no STEMI, and is there any ST depression? And in order to do this, I go lead by lead through the 12 leads. Starting here with 1, this is a pacer spike, so everything here is a paced beat, but I notice right next to that, we have a native beat. Native meaning it's the natural beat of the heart without the pacemaker. And in this native beat, very clearly I see ST elevation greater than a millimeter. And so the next thing I have to do is find out, is it in more than one contiguous lead? Contiguous leads are leads right next to each other. Now here's where it gets a little funky because you just have to learn it in paramedic school. But these 2 leads are contiguous, and these 3 leads are inferior contiguous, and then V1, V2, V3, V4, V5, V6 are all contiguous leads. So if I see ST elevation here, I need to see it here too for it to be STEMI. And if I look over here at this native beat, I see the same thing. That is, the ST segment is definitely elevated. So based on this right here, I can call this a STEMI. Next, I look in the inferior leads because I don't want to just stop here. I want to look through the whole thing. So I'm looking in the inferior leads, and what I see is a paced beat here. So I'm going to kind of rule those out to look too much at right now. And what else do I see throughout here? This, the fancy medical term, is ugliness. So I'm going to ignore that too. Starting with V1, V2, I just look through for whatever it is I might see for signs of ischemia, and I'm seeing a lot of ugliness here that I have to decide. I'm going to wait for a better 12 lead to come along. These are paced rhythms, and when I get over here, this is a lateral lead, and over here are lateral leads as well. And when I get to the tail end here, I do see some signs of ST elevation as well. So right now, based on this, I can call this a STEMI, based only on these two things right here. It would be great to have better 12 leads and repetitive 12 leads, as well as some additional information, but for right now, I can call this a STEMI. And if we look at what the doc in the box interpreted, you see that magic word there too. It's all cut off because the patient label was right in this area, and I had to block that out for privacy. Finally, you'll notice that the hospital puts a stamp here, very difficult to read, but right here, this says STEMI, and this says no STEMI, and the check mark is by no STEMI. And that determination was made at 1948, which is only 2 minutes after the 12 lead was taken. Here's the second 12 lead that they provided the crew, and this one is only 2 minutes after the last one. And in this one, again, is it sinus or not sinus? PR interval, we see a number there, so they think it's a sinus rhythm in the monitor. QRS is 152, so now it's beginning to look like a wide complex QRS. The axis is right there. Is it regular or irregular? Looking pretty irregular still. It's a little junky and irregular. And then we have to go lead by lead looking for signs of ischemia. And just like the last one, we have a native beat here with ST elevation. And if I go to the next contiguous lead, this is the cutoff here. This is actually a pacer spike and a paste. So what do we see here? Yeah, that could be ST elevation in this one too. Little less slam dunk here, but we're still in contiguous leads and still able to call this a STEMI based only on that. Still have some junkiness down in these leads, so no joy there. When we get to the precordials, though, we have a very interesting segment here because this looks like a short run of VTAC. Presumably this is still with a pulse because they were diagnosed with VTAC with a pulse, and we get over to here and we see more evidence of VTAC with a pulse. So we have a patient, STEMI, and short runs of VTAC. What did the doc say? No STEMI there. This is the next 12 lead that they did, and this is apparently about 20 minutes after the last one. Same questions here. Is it sinus or not? No entry in the PR interval, so now we're thinking maybe this is not a sinus rhythm. Don't see any P waves, a couple possible P waves in here. But right now the monitor's thinking no P waves, non-sinus. QRS is being indicated at 48, which is a narrow QRS. Again, I'm seeing some wider QRSs here. So that's a difficult determination to agree with. We don't always agree with the monitor. And the axis here is -83. which is not a scary axis to worry about. And you'll notice also, if I get that out of there, there is a set of vitals, 92/46. Enough to raise maybe 1 out of 2 eyebrows. Certainly concerned based on what we know about the patient. We want to make sure that he continues to perfuse. Then we go through lead by lead again, same process. In here we have what appears to be a native beat and appears to still have that ST elevation. So the next place my eyes go is in the contiguous lead, and here both of these are paced beats, so you can't do that contiguous ST elevation determination. Paced beats here as well, so no joy in looking at the inferior stuff. And then, come on, people, take some pride. This is what's called 60 hertz interference. 60 hertz is the cycle rate of electricity, which means there's something electrical interfering with this signal. The cable might be next to a piece of equipment. They might have taken their remote control for the TV in the nurse call button and set it down on their chest right on top of that V1. But that's some interference, and if I saw this on a 12 lead on a patient that had been showing VTAC in STEMI, I certainly would reshoot this right away to get a nice clean 12 lead. So do we have anything else we can point to for that last question of ischemic changes or not? Well, V1, 2, and 3 are the places that we look for that scarbosa stuff when it comes to paced rhythms, and I don't really have a very clean segment here. So again, not a great 12 lead to go off of, but the doc in the box is ready to make its call of STEMI, and the doc is ready to make their call of NOSTEMI. Here's the last 12 lead, and this one is done at about 3 hours after the last one. I don't know if there were any other 12 leads done in between. I would certainly hope so based on what's going on with the patient and what was on the previous 12 leads, but I just don't know. This, however, is the cleanest and easiest to interpret 12 lead out of all of them. There's no wandering baseline where things are going up and down all over the place, no 60 hertz interference, none of that other stuff. It is clean and easy to read, and it is a paced all the way throughout the entire 12 lead. These are all pacer spikes. It is paced everywhere you look. So every one of the beats is a paced beat. However, since it's paced, we now have to apply the Smith modified Scarbosa criteria if we want to make any determinations about ischemia. So I'm going to forget about all this other stuff that I normally start with. I do take a quick look at that blood pressure of 88/50, and for Smith modified Scarbosa, we are looking for excessive discordant ST elevation, and concordant ST elevation and concordant ST depression in these paced beats. Best place to look, V1 through V3. And what do we see here? I see concordant ST elevation in right bundle branch. Those are the rhythms that are shaped like that. Right bundle branch shaped paced rhythm in V1. So there's one right there, and you only have to see this in one lead. Next lead down, you get a little bit of a notch there, a little bit of a notch there. So there is concordant ST elevation in lead V2 as well. Lead V3 is negative, so it is a left bundle branch shape. So now we have to look for concordant ST depression, and there is indeed a notch there. That's the J point right there. So we have ST depression that's concordant in lead V3. So these are indicators of STEMI, and we have 3 of them under the Smith modified Scarbosa criteria. So this is looking very much like STEMI to me, but not to the doc. Now, I am the first to admit that interpreting a 12 lead is as much an art as it is a science. Whereas others like to remind us every 3 cardiologists will have 5 opinions on an EKG. And so some people are probably looking at my interpretation here of this beat, and in particular in calling that the J point and saying, hold on here, Todd, I have seen plenty of QRX complexes with right bundle branches that look like this. They're notched. We sometimes see RSR prime, we call them, because we see the rabbit ear, bunny ear kind of thing. So how can you be so sure that this is not a notch? It's actually the J point in that QRS. And what I'm doing is taking advantage of the fact that everything vertically that lines up is happening at the same time on a 12 lead. So this pacer spike is firing. It's the same pacer spike, and everything I see on this tracing is happening at exactly the same time in this area as it is in this area. And by taking advantage of that, I can now look for the most obvious sign of a J point, and that obvious sign is right here. This is a pretty convincing J point, that part. And we have it here as well. So then what I do is I draw a line from what I think is a J point and take a look at all the others. I do the same thing when I'm trying to find P waves and trying to measure other things. You draw that vertical line to see what's happening at the same time. And if you do that, you'll notice that down here, what I was convinced is the J point. When I come up here, there's what you think might be a notch. I'm calling a J point. And right up here, it all lines up perfectly. And that's how I'm confident in calling this a J point concordant ST elevation here in a right bundle branch shape, and down here concordant ST depression. Anyone who's interested in how I came to these conclusions in a paced rhythm, why I would still call this a STEMI, and that Scarbosa word and the Smith modified Scarbosa criteria, this is the link to the YouTube video on our YouTube channel that goes a lot more in depth in exactly what Scarbosa is, what the criteria are, and how to apply it. Or you could just go to our YouTube channel and search for Peekaboo ICU. That's the name of the case. Now, there might be people saying, well, what's the big deal? He had chest pain. He went to the hospital. They figured out that he needed to go to definitive care, and so they called an ambulance and they had him transported elsewhere. Well, the big deal is this. The first 12 lead, in which you might have interpreted STEMI, was done at 1946. The hospital called us to come get the patient at 1:25. That's 5 hours of sitting on top of a STEMI. On top of that, we departed the scene with the patient, started transporting at 3:07, and we arrived 52 minutes later at 3:59. Now, granted, it is 3:30, 4 o'clock in the morning, so there's not going to be a lot of traffic on the highway. So you can make an argument that lights and sirens were not necessary for the majority of this transport. But certainly at destination, when you got to that city, I would have upgraded to lights and sirens at a minimum at that point, because I have to act on what I think is happening with the patient, even if the doc thinks it's something else. And in this case, I need to treat a STEMI like a STEMI, and so it should have been a lights and sirens transport for at least part of this transport. Do I have any other evidence to support my opinion that this patient was having a myocardial infarction? Yes, and that's because I got the follow-up information from the destination hospital. You'll remember on the timesheet, 4:15 is when care was transferred to the destination hospital. At 5:35, the patient became hypoxic, unresponsive. They called a code and they found him to be in VFib, ventricular fibrillation. They did a 200 joule defibrillation, which was not effective. They continued their ACLS and gave 3 milligrams of epinephrine. So that is a considerable amount of time going by there, because you give epinephrine every other round of a CPR. The next rhythm check, the patient was found to be in PEA, and then the patient converted into a VTAC. That is a shockable rhythm, so they did another 200 joule defibrillation. Total number of minutes of CPR in progress on this patient, 25 minutes. That's a lot of time to be in cardiac arrest. After they gave that second 200 joule defibrillation, they administered amiodarone in both a bolus twice as well as a maintenance drip. They gave an insulin and dextrose drip, sodium bicarb bolus and drip, lidocaine drip, and a norepinephrine drip. They eventually got ROSC. They took the patient to the cath lab, and they found there to be a 100% occlusion of the left anterior descending coronary artery. They didn't find much plaque in the left main, in the circumflex, or the right coronary artery. Those were all in the 10 to 40% occluded range. That's not enough to do a stent, but in the left anterior descending, which is pretty close to the widowmaker there, they found 100% occlusion. They did put a stent in. The patient, at the last time I checked, was in the cardiac ICU, intubated, and they were weaning the patient down on norepi after having to place an intra-aortic balloon pump, which is a very significant intervention to support perfusion to the heart, and that's a pretty bad sign of cardiogenic shock that they have to put that balloon pump in to keep things moving. And the weaning off norepinephrine, again, is another indicator of cardiogenic shock, or the fact that the heart just doesn't have the cardiac output to support everything, and so they need to leave a pressor in there in order to keep the blood pressure up for a while. But they are weaning him, so he's moving in the right direction. Am I saying here that I'm smarter than the doctor? Well, I've met a couple that I'm pretty, well, that's not even really important. The thing is, you can balance between what we're told and what we see and make the best decision for your patient, and you don't even have to really go against what the doctor is telling you or what your transfer of care report is when you come in to take custody of the patient. There is no harm in treating this like a STEMI. It's not going to change anything other than the speed with which we transfer care onto a cot, into the ambulance, and get going to the destination. You can call it a STEMI in your report, call the destination hospital and say, this case I'm bringing in, I think it's a STEMI. I'm going to transmit this stuff to you, have you take another look, and what they do with that information is up to them. We're not talking about changing anything else. Acute coronary syndrome is acute coronary syndrome, and all the treatments and the things that we worry about, those all remain the same. So the main thing here is the sense of urgency and the speed with which things might have been done, and that is really referring to the age-old prayer of the experienced paramedic, which is, if it's going to happen, please don't let it happen in my ambulance. Let's move quickly. And that's why I call this a call that sneaks up on you, because what the transferring hospital told us is not exactly what we see, and we were caught off guard and perhaps didn't transport as quickly as we could have if we had different information at our disposal. That's the end of this case. I welcome any comments that you have, any criticisms, and if you disagree with me, by all means, shout at the screen as much as you want.